So that is a more complex issue than people realize. And the reason for that is early studies, it was fairly apparent to all of us that maintenance with a FLT3 inhibitor was clearly preventing relapse in a population of patients. Mostly this came out of Sorafenib, which was available off-label and is still used widely around the world as post-transplant maintenance. And in fact, there are 2 randomized studies that show that Sorafenib does appear to confer an improvement in relapse-free survival for patients who've undergone allotransplant who have a FLT3 ITD mutation. A bit of a problem, though. The world has changed. Both of those studies were done with patients who were treated with chemotherapy only and went to transplant in that setting. We know now that patients with a FLT3 ITD mutation in particular, when they get chemotherapy plus a FLT3 inhibitor, midostaurin or Gilteritinib, when their remissions are deeper. And when they go to allotransplant, it's not at all clear that they need a FLT3 inhibitor post-transplant. And in fact, we carried out a randomized trial of Gilteritinib versus placebo for patients undergoing allotransplant who had a FLT3 ITD mutation and were in remission. The large fraction of those patients had gotten FLT3 inhibitors. And while we do not have results from that trial, the relapse rate is quite small, meaning both groups appear to have a low relapse rate, placebo or not. So yes, I'll suspect there's a benefit, but we have to identify the patients for whom that applies. I suspect it's going to be patients with detectable MRD pre-transplant. And for that, you really need a good validated MRD assay, and that is something that we're attempting to validate in this trial. So the question is not at all answered. And obviously the MORPHO trial, which is BMT-CTN 1506, that has finished accrual, but we're waiting on a result, will go a long way towards helping us answer that question.